Subcommittee on the Eastern Travis County. And we're here to have our monthly meeting. Today is June the 10th, 2020, and it is 12 o'clock noon. As a quorum of the subcommittee is in attendance via our video conference, I would like to call to order the meeting of the Central Health Eastern Crescent Subcommittee. The first item of business is public communication. We will receive public communication for both the Eastern Crescent Subcommittee and the Strategic Planning Committee before we proceed to the subcommittee agenda. Members of the public who wish to make comments during the public communication portion of the meeting must have registered with Central Health via the online form or by telephone no later than 10:30 a.m. today. Ivan, did anyone register to make comments?
Manager Jones, this is Ivan Davila with Central Health. There are no members of the public signed up to speak.
Well, if there's no members signed up to speak, then we will proceed on process. But I'll go through the process anyway. Ivan Davila will read the rules briefly covering the guidelines for the public communication portion of the meeting, and will then introduce any commenters by name and invite them to speak in turn. Once you have recognized, unmute your phone, state your name, and provide any comment. There's a limit of 3 minutes per board. So are you saying we have none so far, Ivan?
No, sir, we do not.
Okay, with that said, we'll proceed then with the agenda. Okay, our first item for the agenda today is to review the minutes of the March 11th and May 13th meeting of the Eastern Crescent Subcommittee. Manager Bell.
I move that the subcommittee approve the minutes of the March 11th and the May 13th, 2020 meetings of the Eastern Crescent Subcommittee.
I second.
I have a second. Are there any discussions? Comments? Not hearing any. All in favor say aye.
Aye.
Any opposition say nay. Any abstaining? Not hearing any. We'll go on to our second item then, and that is to discuss and provide direction on process for health care delivery planning and community engagement for interim and long-term facilities in the Eastern Crescent. I'll call upon our staff to go ahead with the presentation.
Thank you, Chairman Jones. This is Stephanie McDonald, and I want to just take you back to our previous meeting in May, refresh you a little bit about the phases that we proposed. We're really going to come to you on items number 1 and 2, the needs assessment and gap analysis, and the service delivery model planning and development work. We have organized a team. They've been busy in the couple of weeks in between meetings, working on developing a process, which they'll present to you today. It's important to remind you that Central Health relies on contracted clinical providers for our healthcare delivery. You know, our default is to go to community care for obvious reasons. They are our partner, and as an FQHC, you know, benefit from enhanced reimbursement rates and can provide a high level of primary care. There are also up to 80 contracted providers through the Central Health Healthcare Delivery Division. And I just want you to know that depending on what we see as needed services in this area by the patient population we serve, community, it may determine that we need to look at different operators. And that's part of why we are doing this work to start. Luckily, there are people a lot smarter than me who are at the table developing this plan and process, and they're being led by Rachel Hardigree. Rachel Hardigree is one of our project managers in our healthcare delivery operations unit. She's also a master of public health. And Rachel, I'll let you go ahead and walk through your process I do want to ask for some direction into how we would engage the community and what kind of process that you all would like for us to embark upon with community leaders, as well as our patient population and others that need healthcare in this community and the Colley Park area specifically. And we'll go to you, looking for that direction. But first, I'll turn it over to Rachel, and Brianna, if you can skip over to the third slide, please. One more. Thanks.
Okay, great. Thank you. Good afternoon, everyone. As Stephanie mentioned, I'm Rachel Hardigree, and I'll be presenting today on a proposed service planning process sort of roadmap, so to speak. And first, I want to take a moment, hopefully you all can see the graphic on your screen, just to sort of orient you in terms of what the structure really is trying to convey. And so what we have here in the center of your screen are 13 sort of darker blue process areas, blocks, process areas or activities that will need to be undertaken to really populate and inform our service plan, our final service plan for Eastern Travis County service delivery planning efforts. And what I've done is I've broken this out with the understanding that this work is not a typical sort of waterfall lockstep process where one process or activity is completed and then we move on to the next activity. This is very much an iterative process. It's a learning process. Once data is obtained, analyzed, and then evaluated, we'll go back through the process to then ensure that all of our boxes are checked, so to speak, in terms of gathering appropriate data. So this visual is really just to kind of help in a logical sense of, in an ideal state, how this process will work. Understanding that it's not a classic waterfall type model, I have attached a timeline that travels through the end of the calendar year and also attached phases of work. And these phases are loosely defined between like an ideation planning to then more in detail or in-depth planning to then that final deliverable, which is the final service plan. Also, you'll notice on the left-hand side is the community engagement, and it's that sort of block arrow. And what that is referencing is that will be incorporated and interwoven throughout these process areas or activities, these 13 process areas. And that will be more finalized with Yvonne's team and also with the community in terms of the level of engagement and communication and transparency. So hopefully that sort of makes a little bit of sense in terms of our overall sort of roadmap of what our process will look like moving forward. So I'm happy to, at a high level, I don't want to take up too much time, but just at a high level for each of these process areas, provide a little bit of information or context that may help kind of inform our thought process in terms of how this flow will actually flow or operate. So the key deliverables, defining the key deliverables, is really translating the desired future state into tangible goals, objectives, and deliverables, which is kind of already in process. Again, this is an iterative approach. So as we learn more, we'll go back and kind of finalize and hone in a bit more on those specific deliverables, goals, and objectives moving forward. The contextual analysis involves consultation with stakeholders and the planning team and staff, community, to ensure that our views and strategic directions are really in alignment with the overall system direction for providing health care. And then the target population is really kind of honing in on a specific identification of specific location of services and the proximity of the population to those who will use health services. And it's really specific to the defined population and defined service area. So again, just kind of honing in that information. This leads us into our gap analysis, which will identify and quantify gaps in health services while also considering future demand for health services. So this is where really the gap analysis flows into the future demand projections for health services as well. So the future demand, the demand projections really digs a little bit deeper further into specific health service types. So looking at, say, for example, specialty services, dental, imaging, those types of really kind of honing in on what those projections look like. Next, we have identifying existing services. So we want to understand the current health service supply in the area, utilization, service delivery models that are already located in this space, and how patients move between these services. So really understanding sort of an environmental type scan. And all of this culminates into essentially a needs assessment, which is the identification of health needs of the target population using the quantitative and qualitative information that we've gathered up to this point through this process roadmap, along with stakeholders to produce essentially a needs statement, which will then inform our selection for a service model to best address those health service gaps that have been identified. As we move into phase 3, our proposed service profile, this digs a little bit deeper. So you'll notice each layer, we're just kind of digging deeper, deeper, deeper to get a final honed in understanding of the population space where we need to expand services. But the service profile really quantifies all necessary requirements to address these gaps that we've identified to date. And then also the operational considerations. These identify and consider operational components where we can efficiently operate services, but also in a sustainable manner. And then service relationships.
I'm sorry,
Yes.
Mr. Chair, may I interject here? If we could ask everybody to please mute your microphones so that...
I was about to say that, Mr. Geisler. Yeah, so there is some background noise in an individual's microphone. So if you please mute it when you're not speaking, we'd appreciate it.
Great, thank you. So service relationships, this is really critical to we really want to understand and define these relationships, whether it's health services, social services, what is currently in the environment where we're looking to establish services, and really understand what that looks like and how it fits into the overall system that we're establishing. And then finally, of course, the financial assessment. So this is the budget to support the preferred service model. So again, all of these pieces, while it seems like it could be very lockstep and one process follows the other, it's all very integrated, and it will be iterative. It'll be a learning process, but I think having these specific activities outlined will be helpful in terms of our planning for establishing a finalized service plan, which we hope to have at the conclusion of the calendar year. So that is my overall sort of high-level overview of our service planning process, our proposed service planning process. And I think with that, I'll close and see if there are any questions or comments from you all. I'm welcome.
Well, before you do that, Ms. McDonald, so are there other parts of this presentation, or will this conclude the presentation on this item?
On this item, this is the presentation. We're happy to answer questions and delve deeper into certain areas if you'd like.
Okay, then.
We're hoping also for some direction and input from you all.
Okay, with that stated, are there any questions for our speakers?
I'd like to ask a question of Stephanie and of the presenter. Is there a full-fledged presentation that we were supposed to have been presented? That's just one slide of the presentation, because I'd like to see the full presentation before I vote on anything. And I see that that's an action item.
We're not asking for a vote. We're just asking for some direction on this. And this is really, truly the process that we want to start with the service planning and needs assessment piece. We would come back to you with a full project plan. That's what we're trying to build to. And when we get to that full budget, so we need to know kind of what services need to be in this health center, making sure that the clinical operator, that we have the right clinical operators. You know, we've been having some initial conversations. Community care is at the table in these conversations right now around developing the process. But this is really just getting, this is a step towards that full project plan. And what comes out of that will help determine, of course, the ask of Central Health and what we need to bring back to you for your approval. It will help determine what the building looks like and how the building might interact. But we also need to, I believe, go back to the community and making sure that we're validating kind of what we are seeing through the data, what we know from the patients that we are currently serving, but making sure that it's also getting to new patients or potential patients, making sure that we're looking at health equity. And if we are seeing things that
Excuse me, I know all that. What I'm asking is, are we talking specifically about one facility, one part of the Eastern Crescent Plan? Or are we talking about that's going to be the approach for all areas and all plans that are going to be developed?
I think we would like to, Mike wants to raise his hand, or he has raised his hand. Mike wants to speak.
Okay, go ahead.
Go ahead, please. Mr. Chair, may I?
Yes, go ahead, Mr. Casey. Yes, go ahead.
So I think as Rachel and Stephanie have indicated, this is an iterative process, and I think it's a starting point, and based on the feedback that we get here today and bring back specific plans. I mean, obviously we want to start with some kind of structure for each one of the areas that we're expanding into. And I think this provides a really good overview of what that structure might look like. But we also recognize that in different areas, we may need to take different approaches, just simply because of the needs of the community or the historical circumstances that affect communities, et cetera. So we understand, that as an iterative process, it is also needs to be a flexible one, depending on the communities that we're working to serve. But I'll ask Stephanie to clarify, or Rachel, if that's not accurate.
I mean, I think we do see this as being a model for any site, but we are going to start right now with the Colony Park site.
And we're doing that, why?
Well, right now, that's where we have more headway, I would say concluded, but more headway on a real estate.
I get it. I understand. I understand what you're saying. I also know that I thought we also had some plans finalizing in other areas, not just Colony Park, because other areas may not have the infrastructure that a city section such as Colony Park already has in place, such as transportation, etc. Now that's just my initial thought, but I've expressed this before. If y'all have decided that you're going to begin with Colony Park, then that's what you have decided. I just want to know who is responsible for making that decision, and who is responsible for saying we're going to start with Colony Park first.
Mr. Giesling.
Yes, sir. Thank you. So Manager Valdez, good question. The board has actually decided the 3 focus areas, and that's in our budget resolution from this fiscal year. So that would be Colony Park, Austin Colony, Hornsby Bend, and Southeast Travis County. So those are the focus areas. We do have activities going in each of those areas per the board's instruction on this. Now, what we've learned as we venture into this world of expanding clinical services is that some opportunities present themselves and some areas move faster than others. And a lot of it depends on the real estate acquisition. I think what is unique about Colony Park is up until a couple of months ago, we were really working under the auspices of, at some point, Catellus will commence work on the master development plan,
Right.
and then we'll finally get around to it. Well, the board, and it's through its action, enabled us at the management level to go start negotiating directly for a land purchase, and so that accelerated Colony Park. Now, at some point, we'll get going on Colony Park, and then attentions will be turned to Austin Colony, Hornsby Bend, and Southeast Travis County. So But again, all of this has been decided by the board through its budget resolution and focusing on priority areas.
Thank
Thank
you.
you.
I appreciate you expanding upon what was already done. But in my head, I guess, I was thinking that we were going to start with all three of them, not just one. And if so, then what's the timeline for the other two sections? Because all
Manager
three were
Jones?
prioritized.
Do you have a board member with a hand up?
I don't recognize. Am I missing someone? Board member?
Chair Greenberg had her hand up.
I don't see Chair Greenberg on my phone here.
Could I get an answer, please?
Yes, I
Sure.
was about to give you an answer, but
Thank you.
is there a board member
Yes.
that?
Sherry Greenberg, I just had a
Okay.
quick
Okay.
question, Manager Valdez, if you don't mind,
Yes.
to elaborate on your question. Thank you.
Thank you, Sherry.
Yes, I'm asking of Mr. Giesland or other staff. I thought that the board resolution said that we would proceed on all three of these. And from what I'm hearing, we are proceeding on all three of these. It's just that we are in different phases of being able to acquire the real estate on all three of these. Is that correct?
Yes, ma'am. That's the principle and the main reason for the different tracks that these three areas are on, and also the pacing of each one of these. And so the short answer to Chair Greenberg's statement is yes, and concur. Manager Valdez, to complete the answer to your question, so yes, we are working on these other three areas. So for instance, there is a land acquisition, I'm just going to say, set of negotiations in place pursuant to the board resolution that was adopted for Southeast Travis County. There is some pre-site utility related work happening in Austin Colony, Hornsby Bend. But again, because each one of these are very different, and I want to be clear and open about this with the board, each one of these projects will move it at a different pace. And a lot of that, and wait till we get to the permitting process, that's really going to be another determinant, which we haven't even gotten to that point yet. But I understand the nature of your question, and yes, they are moving at different paces, but for good reason. Thank you.
I just have one last clarification.
Okay, one more question, Manager Valdez.
I appreciate that, Sir Chair. With respect to the community engagement and input, I want to make sure that we understand that when we're getting input, it's going to be from the people who live in those areas, not people that live in Northwest Austin coming in and being a part of a group conversation and planning and development that do not live in those areas that are going to be most impacted by the development of what they desperately need and have been asking for all along. And the reason I'm saying that is because we're talking about the basis for the needs assessment, the review of the various resources and ultimate development of the plan and incorporation of the building and what services are going to be provided there. We want to make sure that it's based on data from the people who live in that area, not in people that do not live in that area. And the reason I say that is because I've noticed in the advisory committees that have been working in the different areas that the majority of the people on those committees don't live in the area. And I have a real problem with that myself. So I want to make sure that as we move forward and invest monetarily in these areas, that it's truly based on what that community wants and what that community needs. Thank you.
Okay.
Is that going to be the case?
Are there other?
That's going to be the case.
Absolutely.
So yes or no?
Absolutely.
Okay, thank you.
All right, let's move on. Are there other board members that have questions of our presenters? I want to give all board members opportunity to hear their questions answered. Okay, not hearing any. I have a couple of just quick questions. I sort of piggyback off of what Manager Valdez says, and it goes back to something I think I asked a while back. Have we yet to be able to break this Eastern Crescent into parts and analyze and do the analysis of the subsection of the Eastern Crescent. Basically, the Eastern Crescent is the whole eastern portion of Travis County, a huge area, which different needs with different concerns, with different health outcomes, with different facilities. We're moving forward with the process of developing facilities for certain areas based upon the demands of those areas, which are good, makes a lot of sense to me.
Right.
But there are other areas that have not even been assessed that will be and are being impacted over time. So my question is simply, is there a strategy to begin to develop some data that will help guide us in the development of areas outside of the Colony Park, the Hornsby Bend, the Dell Valley area where we've already begun areas? I know we're doing something in Creedmoor, but I mentioned several times Mustang Ridge. There's an area called New Sweden. There's parts of eastern Travis County up around Elgin, and there's areas up in and around Pflugerville. So I just want us to be able to look at the county, the Eastern Crescent as a whole, and to parse it up based upon what we see the health status is before we start making strategies on expanding other areas and before we start building too many facilities in certain areas.
Yes, sir. That's an excellent question. And I'll start off answering on that. And I think there's staff individuals here, but I'm actually going to tie it back to Manager Valdez's earlier question about the advisory committees. And, you know, first, the advisory committees that we're working with, and I've been to a lot of those meetings, they are attended by people, and I know that Yvonne and Jan are on the line as well, but we work very hard at making sure that it's folks from that area. Not that other people can't join in, but through that advisory committee process and by talking to people, yes, actually live there, Manager Valdez, not only are we looking at this from a data standpoint, but from a community level standpoint and their observations, we're able to gain a lot of data. And I think that feeds into the Manager Jones's question, which is, Chair Jones's question, which is, are we looking at these other areas? The short answer is yes. And I think it started off with the demographic report that was recently presented. And if you think about the systems-based approach, which we'll hear about in the full committee meeting, and looking at the different data sets, whether it's the community health assessments, whether it's information coming from our clinical partners, you know, all different sources to be able to determine, okay, what are the next steps here? And I think to your point, Mr. Chair, is that, you know, we want to be very thoughtful and deliberate about these other areas in terms of what we do so that we don't make the wrong kind of investment that won't have an impact, a positive impact on people's health. And I can point to some concrete things I said, like the demographic report, but I think there's more to come on this through the systems-based approach. And also working with the advisory committees that absolutely are made up of people that live in those areas, and even, you know, equally more important is folks that have been patients within our systems either currently or previously, and getting their feedback as well. So I'll stop there because I know there's more specifics that I think will answer your question.
And you've answered my question, so I appreciate that very much. And as we go forth, we'll be able to dialogue more and more at future meetings. I want us to proceed unless there are other board members that have any questions, like to go on to the next item. This item primarily was for informational purposes only. So unless there's any urgent issue, I'd like to go to the next item. Okay, the third item on our agenda is to review and update and take action on the relocation of the Resource Center for Colony Park from Volma Overton Elementary to Barbara Jordan Elementary School. This is an action item requiring an action on that. So with that said, I'll turn it over to our staff.
Mike, I'll go ahead and kick it off. And if you want to add anything, please. Mike is the person who's actually viewed the modular that we hope that AISD is able to move for us. They have agreed unofficially that they could move a modular that is on the Barrington Elementary campus that's being unused over to Barbara Jordan for the start of the school year. The scuttle that I'm hearing is that the school year may start August the 18th. That may not be all kids on campus, so I want to caution, but they have committed to getting this in place by August. What the request is for today is this funding has been approved in the fiscal year 2020 budget, but I just want to come back to you all, given that we have a more defined amount of money that's involved. We believe that it is best and most expedient if we let AISD not only provide the modular, but transport it from Barrington to the Jordan Elementary campus, and then do the installation work. There are some other pieces that we will be responsible for, and we are still kind of waiting for our AISD. There may be some asbestos abatement required. There will be some electric and water connection that they currently believe that they can manage for us. There are site plan review and permitting requirements that they can manage for us at the city. And I think it is easier and more efficient if we let them do that. The current estimated amount is $142,000, which is in your backup, and I'm happy to answer any questions.
Okay, board members, are there any questions before we take a motion? Not hearing any. Are there any? Is there a motion? Manager Valadez.
Yes, I'll go ahead and make the motion.
I'll second.
that we take action on the relocation of the Resource Center for Colony Park from the Volmo Overton Elementary School to the Barbara Jordan Elementary School.
Okay, Chair Greenberg, did you hear a second?
Yes.
Okay, I have a motion and a second. Are there any questions, any discussion on this motion? Not hearing any or seeing any. All in favor say aye.
Aye.
All opposed? Any abstaining? Okay, the motion is approved. So that's your direction.
Thank you.
Okay,
We will come back next month with an update on the services and the service planning, what we'd like to work with the community, and we'll come back with you to you.
Okay, thanks very much. Appreciate that, and glad to see we're moving along, and hopefully we'll have it by August in place. That's a yes. That's not. That's a shaking head. I don't hear.
That is the hope.
The hope is that by the start of the school year, which we understand right now to be about August 18th.
Okay then. Thanks very much. Appreciate it.
I have one request.
Yes, ma'am.
That as we get this report, that we also get an update on where we are at in the other areas.
Absolutely.
Because I want to make sure that we're not operating in a vacuum for Colony Park, and it appears to the public or those that live in the other areas that we have put them on a back burner. That's what I'm most concerned about.
Understood.
Thank you.
And I would concur with you, Manager Valadez. We don't want to feel that any one area is being neglected. So I would concur with that. I think we are taking action in other areas, but I think we need to elevate that and make sure everyone understand that as well.
Thank you.
Okay, item number 5 is receive an update on the plan. No, I'm sorry, I'm skipping an item. Receive an update on the plan land acquisition on the city track for the future Loyola Town Center. Have I skipped an item? I think I thought there was another item. Yes, I'm sorry. Item number 4. Item number 4, I'm sorry. Receive an update and take action on the process of staffing the resource center to be relocated from Balma Overton Elementary School to Barbara Jordan Elementary School. We require an action on that. So first let's have a discussion on it, and then I'll have a motion.
So managers, earlier this spring, pre-COVID, we had posted a position. This position would have facilitated the service planning at the new resource center when it moved to Jordan Elementary. Also start developing some relationships in the community and planning as we started to plan for this larger brick and mortar site. That has, of course, accelerated with our real estate work with the city. Also, we made some, we had pulled down that posting. We had selected some finalists that we thought we would bring to the community to meet, but we are now we revised that job description. We are making sure that the person that is in this role has either healthcare or medical experience or in a healthcare setting, given that there's an accelerated timeline with the brick and mortar site. But I think what we're looking today from you all is how would you like the community engagement process around the selection, the job description review, the selection potentially of the candidates. I know that Manager Jones has some experience in the city that he might feel is appropriate in this for this job. And I think we're very cognizant that this person has to work and be trusted in the community, and having the community feel like this person is speaking with them is important. So I'll just ask for some direction from you.
Okay, let me, before I ask for other board members, make sure the ask of this is to approve a particular position classification or approve a position. I'm not sure about that. Again, I want to make sure.
Or the job description, and it would be really around the job description as well as some direction on how you would like for us to proceed in the selection process.
Okay, and have the board members an idea or been presenting ideas on that job position, job description?
The draft job description was included in the backup packet last week.
Okay, so everyone is aware of what we're talking about. I just want to make sure. So with that said, I think Member Valadez, you had a question.
Yes, I'm sorry, I didn't read the job description, so I apologize for that. But I do want to make sure, knowing the demographic for that area, that this person has to be bilingual required. And that needs to be in the job description. As a matter of fact, I think it needs to be in all of our job descriptions, bilingual required. Unless maybe you remember. And then it does need to really be bilingual required.
I would differ with that. So I agree that we should have bilingual preferred. I don't think we should be requiring that of all of our positions. I don't think that's because I don't think that's appropriate for all of our positions. I think it's preferred but not required.
I agree. I agree that it's needed. However, I believe that based on the demographics for those neighborhoods, that is something we need to look at. And in light of the fact that the majority of the people who have historically been marginalized, aside from the African-American population, is the Latino population, and all of that is coming to light in COVID. So.
For both communities. Manager Greenberg, your speaker,
Yes, I didn't want to speak without being recognized, Mr. Chair. If I'm correct, the way that it reads now is under preferred experience, it says bilingual English/Spanish language capability strongly preferred. Am I reading that correctly? Stephanie?
Yes, ma'am.
Okay.
I think that's an appropriate title. Other board members, questions regarding the classification? Let me ask one. So we said this classification was a manager. Is that correct?
Correct.
So is it conceivable that this person, because of their role in terms of from the beginning of the Barbara Jordan opening to the ultimate facility building and opening at the new facility, the Northeast Health and Wellness Facility, is it conceivable this person could help assist us in mobilizing the community and engaging the community and addressing the community as we build for that facility? So someone who has the ability to do those skill sets are built into that job description as well.
Absolutely.
And that's what we would be looking for that position. That type of person. Okay. Other Manager Valadez.
Yes, I want to make sure that everybody understands, especially those that have HR experience in other arenas, that when you say bilingual preferred, it does not mean bilingual required. And what happens, that's just like saying, we're going to put out a contract for a subcontractor or whatever, or a contract, and we're going to say, oh, we're going to review, we'd like to review your experience with how many minorities do you have employed, preferred, and the preferred never seems to translate to required. And so in light of the demographic data that we have received from Jason and the census data that we have looked at in the past, and we know it's going to be changing for 2020, I would like to make sure that whoever is able to communicate in the community is able to do so without an interpreter. You lose a lot of ability to build that relationship and to gain trust if you cannot speak both in English or in Spanish. And I think that unless you are able to do that without having to have an interpreter present, which doesn't, it doesn't mean the same thing, because then you confuse your audience. If your audience has to spend time trying to internalize what's being said by an interpreter, as opposed to seeing what is being spoken by someone who's speaking a language that is not their native tongue. So I think it's important that bilingual required for our Eastern Crescent communities based on their demographic is something that we have to have, not just prefer. Thank you.
Okay, thanks, Manager Valdez. Manager Bell, you had your hand up for a second. Do you have any comments or questions you wanted to make? You're a speaker. Your speaker.
There we go.
There you go.
I do have a question. Is any of this going to be, are we going to get any input from the community on this position and the activities that they think should be provided?
Mr. Giesland?
Yes, thank you, Mr. Chair. So yes, sir. In fact, that's actually what we're looking for today is direction that we work with established community leaders in Colony Park in a shared decision-making process to assist in this selection. And, you know, in addition to what Manager Valdez has pointed out, really looking to those of you that either through your experience in other governments or, for example, with opening other neighborhood or health and wellness centers. I know Manager Valdez, you were instrumental in Southeast Health and Wellness. Just capturing all the experiences here from this body as to what your advice is and guidance is on working forward. This is a rather unique approach for us because in the past, typically what we've done, at least in my knowledge, with the exception of my position, is we posted and we've hired, and that's that. This is a different approach for us, and it's one we're excited about doing because we think it makes for a stronger connection with the community. And to your point, Dr. Bell, to wrap up the answer to the question, absolutely. We're going to engage with the community on all aspects of this.
Okay, any other, Manager Valdez?
One last thing. I have been a special education advocate for parents and their children for many years. And I did a lot of work at Barbara Jordan because they had such a huge L population, which is English language learner population. That area it's blown up with respect to the Spanish speaking population there. And I dare say that the majority of the people would respond better to someone who is speaking their native language than someone who is taking an interpreter if they are hired. And if we're only talking about one staff person at this moment, you know, I would dare say that would be a barrier that would need to be overcome by the majority of the people who live in that area. That's why I'm standing strong on that with respect to the job description position.
Okay, Mr. Giesland, you had a response.
Yes, sir, thank you. So I think first, if I may, we need to go back and check with HR and legal counsel in terms of what we are permitted to say is required for a position like this, and make sure that we're staying, you know, in compliance. But the second piece to this is that this is not the only person that's going to be active in engaging with the community. And a lot of them are on this call right now. There is a whole team of individuals, both in communications and in outreach and at the board level as well. Myself, Stephanie, Melissa, Ted, could go on and on, that are going to be engaged with this community, as with other communities where we have expansion projects going on. So fortunately, we're blessed here at Central Health to have very strong bilingual capacity between English and Spanish, and we're not going to let anybody go unserved for lack of linguistic capacities, but also the ability to establish trusted relationships with those that we serve. Thank you, Chair.
Okay, and I think we need to move on to the next item. Before that, I'd just like to echo that as we look at this accessibility to linguists, we also need to look at culture as well. That plays a significant portion. And so I think to the degree that we talk about a person who we would look, we want someone who has a wide array of skills, abilities, and affinities. And I think that as the CEO said, we're going to be looking at, we don't require that across the board of all of our staff. I don't think we should. I think we need to be cautious, but I do agree that we need to make sure that our staff are culturally affinitive and they have access to our services and our staff when they are available. With that said, one more point, Manager Bell, I see your hand came up.
Chair, I do believe you need a motion on this, and I would like to make it if you would allow me.
I would appreciate it. That would move us along. Yes, sir.
I move that the subcommittee recommend that the Strategic Planning Committee direct the President and CEO to work with the established community leaders in the Colony Park community in a shared decision-making process to assist in selection of the program manager for the Northeast Health Resources Program.
Is that, yes, okay, thanks very much. Do I have a second? Manager Greenberg has seconded. Is there any discussion? Manager Valadez.
Dr. Bell, will you add just a couple of words as an amendment? It's not only community leaders, because much of our population are not self-identifying as community leaders, but actually the patients and prospective patients for that neighborhood. If there could be a town hall or something where people are solicited to attend and have this conversation, I would hope that you would at least, or our staff would at least consider that as an additional, I guess, additive to the process.
Could I, let me, on that question, before you answer, Manager Bell, are you asking us to add, to amend his amendment, or is that something that could be just taken up as by staff in terms of the process in which they go about it?
Well, when you say community leaders, that is, you're sticking to community leaders. And whoever self-identifies, I'm a community leader. Everybody's a community leader. Well, not everybody is a community leader. I would dare say the majority of the people in that neighborhood do not identify themselves as community leaders. And the majority of the people in that neighborhood is who we need to hear from. And so I understand looking at your advisory committee, I understand all that, but I don't want to limit us in just saying self-identified community leaders. No, I want it to be a little bit more inclusive by expanding that, either or dropping that. Just say the community as opposed to community leaders.
Okay, Manager Bell, are you amenable to that?
I would be amenable if I hear from staff that that is actually something that can be done, that addition.
Staff?
Yes.
Mike, go for it.
Thank you. I think it is doable. You know, you could either strike the phrase leader and strike the words and just say community, or you could add in person served or to be served by this health and wellness center. And we do have some means that we can do that through patient engagement. I know that Steve Vaughn's on the line. I know he's conducted some patient engagement seminars before at the North Central Health and Wellness Center. So I think we have a means to do that. We just need to build it into the process that Ms. Hardigree laid out. And besides, it's a given in my mind that we would reach out to our patients as part of this process too.
Chairman Jones, and I would like to restate my motion.
Okay. And I'll ask for Manager Greenberg to, if she's amenable to that. So go ahead, Manager Bell.
Great. I move that the subcommittee recommend that the Strategic Planning Committee direct the President and CEO to work with established community leaders and current and potential patients of the Northeast Health Resources Program in Colony Park community in a shared decision-making process to assist in the selection of the program manager for the Northeast Health and Resources Program.
Second.
Okay, I have a motion and seconded.
I want to thank you.
Further discussion? Not hearing any. All in favor say aye or raise your hand.
Aye.
Any opposition? Any abstaining? The motion is carried. Thanks very much. Okay,
Thank
let's
you.
go to our last item, which is receive an update on the planned land acquisition on the city's track for the future Loyola Town Center. It's an information discussion. I have roughly 10 minutes for us to go, so if we can do it in 8, that would be fine. Staff.
Yes, and I'll try to keep it under 8. We are currently engaged with the city on purchasing, directly purchasing land within the planned Loyola Town Center. This is the 208 master plan community for Colony Park. This was a strategy that was ratified by the board's approval of the authority for me to directly go into these negotiations with the city, and I thank you for that. Where we are right now is we've identified some acreage within a 5-acre tract. It's approximately 2.1 acres. We are expediting through the city a property valuation so that we can ultimately sit down and start negotiating on something. Obviously, these transactions have to go through various approval levels, but we'll keep you informed on that. But just wanted you to know that we do anticipate getting a property appraisal back here. Probably, I would say maybe within a 30-day window, unless there's some delays that have come up in the past 24, 48 hours. But that's what we're looking at. And then I can come back and tell you, okay, this is approximately what the market value is for the property. And through the authority you've all already granted, then move forward on a purchase unless there's some objections by the board in doing so. But that's in the report.
Okay, any discussion, questions? Any board members? I don't see any having any. I just have I guess one question, and I think we've discussed it several times. We've constantly, and as we go forth, we want to make sure we're on the same page. We're talking about 2 acres, but we've been talking for quite some time about the 5 acres. So what is our strategy for engaging community people who may have a question? Well, what is your long-term plan for the possibility of the 5 acre?
Manager Jones, I want to apologize. I saw that Stephen Lamp was on the call. If I could come back to my prior answer, if I may.
Yeah.
Stephen, was there anything that I left out or didn't accurately characterize based on your knowledge?
No, your characterization, is correct. Chair Jones, if I can address your question a little bit. The City of Austin had broken off or identified initial potential 5-acre tract out of the 208 acres of their master plan community. The program requirements from Central Health have been revised, much due to Community Care's purchase of the carousel properties and practices, because what had been targeted for pediatric services are actually now distributed around the area. So the initial land need and the initial concept of building size or clinic size has actually been scaled back a little bit.
Right.
The discussions we're having with the city, though, are basically an initial 2 acres plus or minus with probably right of first refusal, so that if we need to, we can expand either horizontally. We are also looking at design, or when we start the design process, we're looking at the potential to increase the facility size so we can expand vertically and still basically accommodate a much larger program than we're targeting right now still within the 2-acre site.
Okay, that was very helpful. I appreciate that. But I just want to make sure, because you raised the issue that at least to my knowledge had not been inculcated in my discussions that much. And then there's the carousel purchasing. Does that imply that particularly our maternal and child health services will be not at the Colony Park, but will be at the carousel location? Is that the plan for services for that population? Ms. McDonald?
That is the work that we laid out, Rachel Hardigree laid out in the process. We are looking at all of those components in this planning process, this needs assessment. Maybe they're not getting to all of the children and moms that need care. Maybe there are other services that are really needed in this community that are separate. So I don't think we know the answer to that yet. And I think we'd like to be able to do this planning work and bring it back to you with a service model discussion.
Okay, thank you. That'd be helpful. But the understanding is that we're still looking at that 50,000 square foot within the two acres. So is that a correct interpretation, Mr. Lamb?
That is correct, sir.
Okay, all right then. Thanks very much. I appreciate it. Any other questions on this item? It's not a action item, so I just wanted to see if there are any other questions. Not hearing any, then yes, Manager Valdez.
Maybe it might be better served with an offline conversation with Stephanie, but I'd like to know how many people were actually serving at the carousel site location right there across the parking lot from where our original Northeast Clinic used to be. Since I was there protesting its closure, I'm curious as to how many people have been there and are being served there.
We can certainly request those numbers from community care.
I appreciate that. Thank you.
Okay, no other questions from board members of the night. So we'll go to our last item. It's confirmed the next Eastern Crescent Subcommittee meeting. I have tentatively have that scheduled for July the 8th at noon. Is that a correct time from my understanding from a staff?
Yes, it is.
Chairperson. Greenberg. Is that your understanding? Okay. Okay, with that in place, do I have a motion for that and an adjournment?
So moved. I move adjournment.
Second.
Okay, we consider ourselves adjourned at 12:56. Manager Bell and Chair of the Strategic Planning Committee, I give you 4 minutes.
Thank you, sir. I appreciate that. I can always use a good 4 minutes. Since the agenda, and David, correct me as I'm wrong, but I think I can go directly into the Strategic Planning Committee, or is it set at 1?
It is set at 1, so we should take a short break.
We will take a short break.
Okay.
Everyone needs to be happy about that. And we will return here at 1.
May I ask a question?
Yes, Manager Valdez.
Dr. Bell? Yes, Dr. Bell, I'd like to know if we can have just, if you will call for a moment of silence in respect to the George Floyd
Yes, I will.
funeral yesterday and the possibility for effective change that can occur as a result of his martyrdom.
I surely will.
Thank you.
Thank you, Manager Valdez.
Okay. Good afternoon, everyone. My name is Charles Bell. Today is June the 10th, 2020, and it is now 1:00 p.m. As a quorum of the committee is in attendance via our video conference, I'd like to call our meeting to order, and that is the Central Health Strategic Planning Committee. I'd like to take up agenda item number 1, review and approve the minutes of the March 11th and May 13th, 2020 meetings of the Strategic Planning Committee. May I have a motion?
I'll move.
Thank you, Manager Musaitif. Do I have a second?
Second.
Thank you, Manager Valadez. I have a motion by Manager Musaitif. I've had a motion by a second by Manager Valadez. All in favor?
Aye.
Aye.
Any opposed? Any abstaining? Motion carries. Okay. Item number 2, discuss proposed fiscal year 2021 strategic priority focus category, improving access to care. And we will have a presentation. I think I'm going to turn it over to Monica, but Dr. Jewel Mullen, who I'm very happy to see here. Thank you for joining us today. And Dr. Alan Shalsa. Thank you, Dr. Shalsa, for joining us today. And Monica, can you kick this off for us?
Yes, thank you, Dr. Bell. I'm going to start sharing my screen. And can you guys all see that? Thank
Yes.
you. And I'd like to also thank Dr. Mullen and Dr. Shalsha for working on this project with us and joining in on this work, as well as presenting today. And I'd also like to recognize Jonathan Morgan and Sarah Cook and Sarita Clark-Leach, Cynthia Gallegos, and JP Eichmiller for the work that they've done on this presentation. And let me see if I can move to the next slide. And this presentation is one of 5 presentations that we are going to be doing this month and then next month in strategic planning and budget and finance, that Dr. Bell had said last month when we presented on proposed fiscal year 2021 strategic priority focus areas, that we would come back and have a broader discussion with this committee and with the board on those proposed priority areas. And so each presentation we're going to ground in the board adopted strategic plan for fiscal year 2019 through fiscal year 2024, and tying these proposed priority categories to the strategic plan objectives that underlie each category. And the presentation today is on the proposed fiscal year 2021 priority category, improving access to care, including capital planning for additional clinic locations in East Travis County. And this proposed category addresses all 3 of the strategic plan objectives. The presentation today really is focused on the track around taking a systems-based approach to service planning and care planning grounded in equitable principles in order to best meet the needs of the population that we serve. We spoke in the Eastern Travis County Subcommittee before on the other track of this work that is continuing the immediate work on the clinic development in East Travis County. So both of those tracks are essential, you know, to our work going forward. And this one, we are talking about just this one aspect of the systems-based planning aspect of this proposed priority category. And then we'll come back to talk about it, do a deeper dive on the ongoing COVID-19 response priorities, on enhancing clinical programming and supporting transformational operational initiatives, on implementing the hospital funding model, and on redeveloping the Brackenridge campus proposed priorities in the next month. So before I hand it off to Dr. Mullen, we do want to just say at a very high level what taking a systems-based approach is. And when you take a systems-based approach to planning, you both recognize how the structures create the conditions that we're facing and trying to improve, and also explore problems completely and accurately before deciding what the next step is. And this assures that our priorities and decision making are informed by relevant data. It expands the choices that you have to solve persistent issues that might not, you know, be gut instinct choices or things that, you know, it jump off the page at you. And this allows you to create more satisfying long and short-term solutions to things that are chronic problems, which supports equity by improving quality across the framework of our entire continuum. And now I am going to let Dr. Mullen talk about some of the goals of taking this systems-based approach. And I'm going to go on mute.
Thank you. Good afternoon, everyone. For those of you whom I've met before, I'm really happy to see you again. And for those for whom it's my first introduction, I'm trying not to mess up because I am so grateful just to be a part of this conversation. I just want to share, it's been just about 2 years since I met Monica, a little bit more than that, since I met Mike, Shannon. I'm sorry I'm doing first names. I know this is a more formal gathering, and others. And one of the reasons I was most excited about taking a position at Dell Medical School was, regardless of what anybody else was doing, I knew it was a fantastic opportunity for me in my role to be a part of what was happening with Central Health, and then know what I could bring and offer to that. So I know I am a person with a name and a title, and what you get today is a person with a name and title, but mostly what you get is me. And I'm looking at your face, Cynthia Valadez, so you've seen me before. And so I'm not looking at Mike Gieslin's face at this moment, but I choose not to, because I want to start in talking about equity, understanding from almost 2 years worth of conversations that everybody really wants to get this right. And the notion of being equitable and thinking about what fair means is one that has made people want to do so many things in a way that it's almost as if it's hard to let go of anything, but it also can move all of us into tactics instead of really being able to step back and say, what's the big picture that we're trying to create for the people we're trying to serve? And I will tell you on this June 10th that some of my greatest joy in my work, and I still like my job, is when I get to have conversations like this, because they're comprehensive, they're challenging, and because the way in which I think about Central Health in colloquial terms is that central health should be the dog wagging the tail as opposed to somebody else wagging central health. And I see that with a perspective of wanting to believe that this group really has is the visionary to drive the system, to create the actions, to improve well-being across the county. And I don't work with you all formally or for you, but I spend a lot of time telling people, but central health can't do it all. Nobody can do it all. And when I worked in government, I used to say, government can't do it all. And then people started thinking, oh, what political party is she in? But it wasn't even a partisan statement. It was just the reality of what happens when there are limited resources and so many hard decisions to make. So with that, I am really happy to talk about a systems approach because I, in getting to Dell Medical School, had people say to me, so what equity projects are you going to work on? And I would say, equity's not a project. Equity's not a project. It's a value, it's a principle, it's a guiding principle. And if we're really serious about it, we need to look inside of ourselves and see what we are and are not doing that is keeping us from achieving the opportunities for people to be as well as they can be. And that is really then starting with not only data on what's going on, but also a serious self-assessment about how well our well-intended current approaches actually are achieving their intended outcomes. And I appreciate Monica starting with structures, because I've been reminding my colleagues who just want to talk about outcomes, up the street and around the corner, that your outcomes are driven by your structures and your processes. And if you really want to be honest with yourself about how you have the outcomes you currently observe, one of the ways to do that is to look at what you're doing, but to also be honest with yourself that if you really want to improve care, you need to be able to look yourself in the mirror, which as a system means looking at your data now and saying, here it is, whatever it is, it's our starting point. It's not our mea culpa, it's nothing else other than our starting point that we want to work from. You have to look at me and tell me if I'm talking too long, Monica. So with that in mind, what I want to convey beyond maybe the affirmations for this process and the gratitude that you are inviting me into it is that I also see accountability for my employer, Dell Medical School, to be part of this system as well. And many of you have been informing me and informing us in the work that I've been doing at Advancing Dell Medical School at the same time. So a systems approach gives us the chance to look at health and health services, not being those that just exist inside four walls. They're not a bricks and mortar process. They really are a systems process. And having been the medical director of a neighborhood health center, I know that even when I thought about my community, when I looked at the zip codes of the people who we served, some of them came from suburbs outside of Springfield, Massachusetts. Some of them came from many other places, because no matter how much we say, if they build it, they will come, it doesn't always work that way. And a lot of times, even if it's built, people don't come if our systems and structures don't serve them. I think I would just end at this point by saying, I hope that this process incorporates both a perspective that informs us about the life course, as well as the health continuum, because it's a little bit of both, right? We're talking about populations, not just a particular age group, and we're also talking about everything from this system acknowledging that there's work that gets done in public health and beyond the acute and chronic care settings, in a way that I hope there can also be some embracing across the county of what community accountability does to feed into this process, because I think there's opportunity to build the partnership and capacity with community serving organizations that provide a lot of the services that go beyond healthcare. I can stop there, and I hope I addressed what you wanted.
Sure, and Dr. Mullen, would you like to speak, introduce this slide before we hand it off to Dr. Shalsha?
Sure.
And
Sure.
I think you did a little bit. But
Yes. So the way in which I think about this as somebody who's an internal medicine primary care doctor and public health person is to continue to understand that even when tasked with that component that's mostly the medical care services, there's so much more that goes into a system. And so as Central Health goes through this process, as you go through this process, I think there's an opportunity to push policymakers as well as the other players that I want to see, and players, I mean people like Bell Medical School and Ascension Seton, who are also accountable for the well-being of populations, to see what their role is in this. So I looked at a variety of different models, didn't make it up. There's the attribution there. But as I saw this, based on what Monica and Dr. Shalsha were talking about, it seemed that this schematic most depicted what they were talking about. And somebody asked me, well, where's Central Health in this? And I said, well, in part, there's system leadership. I really do. Central means a lot of things in that regard to me, in terms of setting the vision and then holding others accountable to it. And I understand from where I sit that both on the Ascension side and the Del Med side, perhaps that means that there's some other deep dive we need to do in our own thinking about accountability. So system leadership is Central Health, but it's also that coordinated leadership that in the strategic map that we made for Del Med with our partners calls out a more evident and impactful leadership across what I have called the triumvirate: Central Health, Ascension, and Del Medical School. But I think the other reminder there is we have everything from public health to hospice and palliative care that's incorporated, and many, many different actors who contribute to the well-being of people across that. Dr. Shalsha, would you like to pick it up from here?
I would love to. Thank you, Dr. Mullen, and thank you, Monica. Can everybody hear me okay? Okay. So thanks for this opportunity. It's incredibly exciting to start out with kind of my first presentation to the Strategic Planning Committee, with really talking about systems of care. And the only other aspect that I would add, to comment on this slide, is that the system, whatever system we look at, the system is not static. That at all times we need to look at the system, we need to challenge ourselves, we need to challenge the system, and we need to make improvements based on the needs of the communities that we're serving, and where our strengths and weaknesses are. So it is a continued cycle. Monica, if we could please go to the next slide. What I hope to share with you all now is really the key components to part of a system that we have now and part of the system that we hope to develop. The key components that I'm going to share are aspects that we thought were important to share. It is not completely comprehensive. The system can be looked at differently. And I won't touch on all aspects in an effort to avoid people from falling asleep. But with any system, we have to have system design goals. What are we aiming for? And as Jewel really spoke to, we need to really look through a health equity lens, right? So the design of the system, it's a culture, it's a methodology, and it's an outcome. Are part of the system. It really needs to be comprehensive and coordinated, and we need to ensure that the population that we're focusing on remains to be central to what our task is, and just true that up. One of the things we've realized through COVID is that technology is central to really achieving healthcare success. And so whether it's remote monitoring, whether it's Bluetooth, whatever the technology aspect that we need to utilize, is we need to consider it, because without technology, I think we won't achieve success as efficiently or as quickly. And so technology has to be key to our model. We have to have effective and efficient care model. Patients need access to care when they need access to care. I think that states it all. We need to utilize evidence to determine both our methodologies and to check our outcomes, right? So feel-good medicine is one thing, but it doesn't necessarily decrease morbidity and mortality, which is our goal. So we need to ensure that our quality outcomes are evidence-based, and we need to long-term really look at our disease prevalence and our longitudinal, how long people live, and make sure that we are improving those aspects. In addition, and this is probably the most important, we need to make sure that the work we're doing is deemed important by the patients, right? So if we improve an A1C and patients don't feel better, we've missed the mark. So we have to ask that question. And lastly, it has to be affordable. All right, Monica, if we can please have the first components. All right, so we're looking at the components of a healthcare system as gears that have to work together. Public and community health, whether it's for education, whether it's for bringing partnerships together, or whether it's for primary prevention, whether it's immunizations, are really critical. Primary care, I'll talk a little bit more about. Specialty care, hospital care, and post-acute care, I will speak to as we add onto our gears. Monica, can we hit return again, please? And one more time. Perfect. Within the primary care scope, we're including medical, dental, and behavioral health, right? Those are really central to what we consider primary care. Urgent and convenient care offer same-day access, and in an efficient and an effective system, they not only offer same-day access, but they tie into a primary care model where when somebody comes in for a cough or a cut, if they do their colonoscopy or their mammogram, we can order that, because that is what is going to improve morbidity and mortality, not the fact that we gave them cough medicine and they go home and they feel a little better because they took they had a takeaway. So we really need to look at our longitudinal approach and again, look at one of our goals to ensure that we're improving morbidity and mortality. Our expanded care teams are more and more an important part of our care model and of our overall system. Pharmacists, behavioral health individuals, community health workers, dietitians, we no longer sit looking at the physician or the advanced practice provider to be the captain of the ship, because that is a rate limiting step. When he or she controls the access to our system, we need to continue to empanel our additional expanded care team members to move and advocate for care as to their ability and to the top of their license, because we will run care in parallel and we will create much more access as we continue to advance that. As related to specialty care, there are specialty care environments where we do have good access. There are other areas where we will continue to improve access. And as we continue to present on our systematic approach, so we'll dial down more into the details as to which specialties we have a better opportunity for, or we have greater opportunity for in the future. The more outpatient surgeries that we can conduct when appropriate, the better. It's easier for our patients to navigate. It's less expensive to the system, and less expensive to the system means that we can reinvest those dollars in areas where we have great opportunity. As far as hospital care has to be integrated to our general system. It can't live as an island. It can't live separate from the rest, whether it's outpatient diagnostics or surgeries, or inpatient or traumatic and emergency care. It has to function with the greater, with the other components, and it has to interrelate, and I'll speak more to that in a moment. As far as post-acute, this is an area of significant need. If any of our components are not well sustained or are missing, they almost serve as kind of cracks in a dam where patient care leaks through, where we cannot wrap the patient. And as far as the system, patients pay the price in the short term and the system pays the price in the long term. Care ends up being more expensive if we don't have a skilled nurse facility, right? Patients may have to stay within the hospital for longer. If we don't have home health, either within our environment or contracted home health, and anything we can actually have within our environment, we can utilize internal data to then advance care that is specific to our environment and culture that is specific to our environment. The patients that we are empowered with taking care of have unique needs. And I think looking at the cultural specificities to that care can't be overlooked. Also, end of life or palliative care are a significant aspect as far as our overall care components. We have to do it right, and cost is a factor. We can be very sensitive to our patients and also do conduct care efficiently. All right, next gear, please. Now, we understand that we can't wrap everything perfectly within these individual components, that there are areas that live between, let's say, primary care and specialty care. And I'll give just a couple examples of this. I'm not going to focus on everything. Within primary or between primary care and specialty care, and actually in some ways between hospital care, we are going to call these clinics intensive outpatient clinics. They are clinics that are too complicated to live in isolation within primary care, but these patients don't necessarily need to be hospitalized. I'll give some examples. Patients who have a diagnosis of HIV, patients who have addictive disorders, patients who need dialysis but don't need to be inpatient, patients who, we actually have a clinic called CareCo, patients who have chronic conditions and are medically complex and either being discharged from the hospital but are not wrapped enough to send back into primary care because we want to ensure that their care is really comprehensive and that they are stable enough for primary care to avoid them being readmitted. These clinics really involve a more wrapped services, more intensive personnel and divergent personnel, but can really serve our population well, and again, be lower cost as we cater to those we need to advocate for their care. I'll look now towards between hospital care and post-acute care, medical respite. We have great opportunities here. Many patients have to stay in hospital because they don't have a safe place to go to for a wound to heal. They don't necessarily need the high acuity of a hospital or a skilled nursing facility, but can't be discharged either to the street or to an unsafe home environment where the infection would either grow or they wouldn't heal. And so this seems like a very small aspect of our overall system, but if it is not well defined and appropriately set, our patient care leaks through that environment. Our patients are not wrapped, and overall the system is not serving those within our charge well. And so we've got some opportunity there. Next gear, please. All right. And central to make all this work really are four things. Number one is we need to have a unified formulary. Patients who are placed on medications in any of these settings need to be able to transition with their medications. If patients are placed on medication in a hospital setting and are not able to either afford or attain their medications when they're discharged, we drop care. Care management, our system is complicated. And though we've pictured it here as kind of a fine-tuned machine where the gears really interlock and they work fluidly, we all know that it doesn't work like that, right? So we need to handhold our patients through these care modalities because there are challenges. Shared patient records. If we can't share patient records, patient care suffers. We have to transition those records through in order to continue the care, not start again, and not duplicate either a diagnostic or an evaluation that has previously been done, but we have no idea because we can't get our hands on those records. We have to share those records. And lastly, we have to let data guide us. right? As to our outcomes, as to the investments of our resources, are we utilizing them appropriately, right? And then that PDSA, that cycle of continual improvement where we challenge ourselves in order to improve the system to cater to patient needs is central to what we need to do. Okay, Monica, I'll stop there.
Thank you, Dr. Shalsha. So in our final 2 slides, we're going to look at this short and long-term indicators and measures of this work. And then also in the final slide, look at what the very initial phased work just for the end of fiscal year 20 and fiscal year 2021 is. But looking out over the next 10 years, this work includes work that is identifying and addressing gaps in the current system, using data both, and I always hate, we're trying to de-jargon things, and so, you know, everybody says qualitative and quantitative data, but we've talked about it in the previous committee, using both the numbers that we get about outcomes in the current service, but also the information that we get from talking to the community, from talking to the advisory groups, from directly reaching out to the people that we serve, to take in that is meaningful data that we have to use in these planning processes if we're going to build out a system and prioritize addressing needs of the populations that we serve. Is to speak directly to those populations to make sure that the approach we take is going to be meaningful to those populations. So in the short term, end of this year and the next fiscal year, the measure of our success would be if we could agree upon the attributes of what this system of care should look like across the continuum in Travis County. We begin work to try to improve the connectors that Dr. Shalsha talked about, tying the system together in the previous slide, like improving data structures and record sharing and transparency regarding services and funding, and agreeing upon care management structures and shared scheduling and shared formularies, some of the things that Dr. Shalsha was just talking about. And then we would develop and prioritize interventions to address gaps that we could include work for the 2022 budget. In the medium term, we would continue that work, which medium term we're looking at from fiscal year 2022 through fiscal year 2025, continuing that work to improve these kind of central foundational functions that tie everything together, and then start making sure that we are achieving some of these targets, like making sure that we're serving more people in this outpatient system and moving people from the inpatient hospital-based system to this outpatient system Dr. Shalsha was talking about, meet defined target times for access to healthcare services, and build complete pathways for care of top health conditions, and completing other quality improvement initiatives. And then in the long term, in this 5 to 10 year period, we would like to start, if we're measuring success would be measured in, have we improved morbidity and mortality? Have we improved patient-determined and patient-reported quality of life measures that Dr. Shalsha was talking about? And have we reduced identified disparities in health outcomes? And I think that when we talk about building complete pathways for care of top healthcare conditions, I think Dr. Mullen had an example of what that might look like related to something like hypertension. That we will look at the data, but we know that that is something that's an identified disparity for many of the people that we serve.
I guess that was a cue. So I'll share that I've had a conversation with a colleague recently who picked out a piece of what Dr. Schulze mentioned. He talked about how important it was to know that patients were satisfied and felt well with the care they were receiving. And for them, for my colleague, that was it. Just what did the patient say? And so I wanted to mention that with regard to hypertension, because my comeback was, well, that's great, but if somebody had hypertension for a long time and liked the care they got, but they're on dialysis now and we're happy with the care, even when their blood pressure wasn't controlled, then it's not enough for me to know that they were happy with their care. So be glad you don't work with me. So with hypertension as a model, then what I would say is, and there's salience even with COVID when we think about risk factors for mortality for individuals with COVID-19, especially Blacks with underlying medical conditions, hypertension being a risk factor. A system enables multiple community partners, so that whole care continuum and the big gear in the middle that includes pharmacy management enables a system where that communicates across, sharing data with people all invested in the well-being of people and populations with hypertension, so that that compendium of pharmacy benefit and formulary alongside care teams, that it doesn't matter whether it's the doctor, an advanced practice practitioner, a medical assistant who takes a blood pressure but knows who to say, look at this, what should we do? So that there's always sort of real-time communication in the course of what's happening. Somebody who comes in for something unrelated, an earache, but they get their blood pressure taken and it's too high, but the system is working in a way that they don't have to come back to deal with the blood pressure just to have their earache taken care of today, if you get the point. Having the real-time data, the feedback that also enables pharmacists not just to be dispensers, but to also be part of a care team for medication treatment management is that expanded kind of system that happens at the same time that those in public health are working on things like access to food and physical activity. And as people sometimes inevitably transition into more complex care, those other more complicated patients who still have renal insufficiency and other needs are still being cared for in this model. But it's all in a system that knows patients and knows populations across the continuum. And that's part of what this enables, no matter where people are, no matter where they go. I'll stop there.
So this is our final slide, and what this one depicts is really what we have proposed as the initial phases of this work. And if you notice, the initial phase of this work begins in Q4 of fiscal year 2020 with benchmarking of taking this look in the mirror that Dr. Mullen had mentioned, and benchmarking our system across other both systems in Texas, such as the system in Dallas, the system in San Antonio, and also systems that are high functioning systems across the country, like Denver Health, like the system of care in Indianapolis, and other systems, to really determine across the continuum that Dr. Schulze and Dr. Mullen described, where are we today, and assessing the needs of the population that we serve and what those gaps are, so that we can then continue the work in fiscal year 2021, starting to set goals around this is what, and we would of course bring this back to you as the Board of Managers at every level, so that we can identify and set goals around what does the system of care in Travis County need to look like, particularly for the population that's being served by Central Health and across the continuum that Central Health, that it is our obligation and privilege to serve, and identifying what that system should look like, and then working with the different partners across that system to determine what is the role of those partners, what's the role of the providers, and then also working with the community on gathering feedback about what the community perceives their needs are, and also some of these broader services that Dr. Mullen was talking about, that, you know, it wouldn't be Central Health doing all of this work. It would be convening and collaborating with other service providers. And Manager Valadez, you mentioned working with the school district, things that, you know, and I know that Yvonne and Ted and Jana and that team they've been with the advisory committees reaching out to other parts of the system, but formalizing our approach to working within these structures and recognizing the different roles that different organizations have, both as provider organizations, community-based organizations, advisory groups, philanthropic organizations, healthcare systems, and those roles. And then also looking to, by this time next year, be able to use this system to recommend additional priorities for the fiscal year 22 budget that we Central Health would want to make capital investments in, make programmatic investments in, make investments of time and resources. And so we're not, this is not an action item today. This is a deeper dive. You know, we are very excited, you know, to begin this work. And we feel like with Community Care, Central Health, and UT Ascension with Dr. Mullen and her role, that we can begin this work in a meaningful way, starting this month, next month, you know, if that seems like a direction that that you guys are supportive of as a board. Dr. Shalsha, Dr. Mullen, do you have, John Morgan, anyone have any input as we wrap this up and open it up to questions?
None for me.
Okay. Thank you, Monica, Dr. Mullen, Dr. Shalsha. Really great presentation, lots of great information. And so I would like to ask the board members, do you have any questions? Okay, I see Manager Valadez. And I see Manager Jones and Musai Teeth. And did I see your hand, Manager Oliver? No, okay. Manager Valadez, Manager Greenberg. Okay, Manager Valadez, you first. You're muted.
I'd like to start big picture. Dr. Mullen, it's great to see you. But I'd like to know, has Central Health entered into a contract with you or Dell Medical School to do this?
No, not that I'm aware of. This is just me, and there is no contract with Dell Medical School that I am aware of.
The reason I'm asking is because I've seen all of this as it relates to public health. We are not a public health entity. We are created under Chapter 281. We deal with indigent care, vulnerable care, uninsured. So not Dell Medical Health, not public health, not all this other stuff. I want to talk about our population, and the demographics of our population is majority Latino, then the other populations. And when we develop a systems approach, you have to have that lens, as you and I both have spoken about, present at the table as plans are developed. And I'd like to know where the other lenses are as I'm looking at this. Because when I hear public health, and I read all over the place, public health, community health, and I know our targeted population, as we were created to do, was to deal with the indigent. I want to know whether or not our dollars are being spent on something that someone else should be doing and not on what we should be doing as Central Health. And I'm not angry at you at all. I just want I just want whoever is listening, especially our CEO and our board members, to understand if we need to have a discussion about what our role is, then I'd like for us to have that discussion, because I've asked for it for years. Before we start dealing with what we know is historically racist institutional system, and making sure that we have all the lenses necessary to be able to develop even the beginnings of a plan. And so if somebody can answer that, I'm assuming, Mike, it has to be you.
Well, may I just finish first, because so I lost my screen, so I got distracted and want to make sure I made my point. I'm
sorry, Dr. Mullen. Maybe I shouldn't have asked you the question. I guess I should have asked Mike the question.
Well, but may I?
Because I don't know what you're doing here then.
Manager Valdez, would you let Dr. Mullins finish, please? Thank you.
You asked me a very specific question. I want to make sure you heard my very direct answer to.
Thank you so much.
And so I hope you heard me say no. I'm not on contract. I'm the same person who answers invitations to join a process. And I gladly accepted this one, particularly because the group really wanted to get my input on equity. I'm a primary care doctor who happens to know a lot about public health. I don't separate the two. I also know there are places where public health does a lot of direct care. And I also know there are many challenges to delivering comprehensive primary care when the service of making people healthy is about more than a medical visit.
I understand that. I understand that. But I guess, as you finish, then I guess I want to hear from Mike.
Right. I can also tell you that the invitation to participate in this discussion came to me and has nothing to do with my boss or any kind of a contract.
From whom? Who invited you?
Monica Crowley.
Okay. Thank you.
You're welcome.
Thank you very much. Mike.
And I love your presentation. Thank you.
Thank you, Manager Valdez.
What about the other aspects of my concerns?
Well, if you just hold on a second.
Yes, yes.
Right. Mike, I'd like to recognize you and then John to address Manager Valdez's issues.
Yes. So thank you, and thank you, Dr. Mullen, for being here. And yes, it was by invitation because you are beyond an authority in this. I mean, you really have reached a level of thinking that I think has greatly benefited this system and things that you've done in prior professional lives. And just so the board knows, I've reached out to her impromptu and sought her counsel and insight on things, even on the Saturday before Easter holiday. And so she graciously took my call, and we had a very good conversation. And so, thank you for assisting us and guiding us and leading us in these endeavors. So we really do appreciate your input on this and your guidance and your leadership and your thought processes. So I think, she answered the question regarding contract. There is no contract. This is by invitation to us, just like we invite other partners in to come in and visit with the board committee to inform. With respect to the public health comment, I'm not so sure I fully follow where you're coming from, but let me just say that Central Health is a hospital district. We are not attempting, nor has the board asked us to become a public health authority. That is not the goal here. That is not the intent, and that is not the direction that the board has set. As far as I'm concerned, we are still acting in the lane of a healthcare district. However, as we have gone from a healthcare district that was formed under certain auspices, and there was a clinic system that was migrated over from the city and county to Central Health, and it was fee for service, and now we've gone to value-based healthcare, we're growing up and taking the next big step, and that is taking this systems-based approach. That requires us to not just acknowledge, but to look at that public health component and make sure that, as on slide 38, as those gears are connected, that we're doing everything that we need to be doing. And I'll defer to John Morgan here in a second, but we've got part of our care management team that serve our MAP and MAP basic patients. If there's a social need that needs to be met, I know that they're working, even during this pandemic, to connect people with those necessary services that address those social determinants of health. And so, I think just if you just look at the visual that was given, it's making sure that we're navigating and coordinating, but not becoming public health. We already have a public health authority, an organization, an agency here for Travis County, and I think enough said at that point. And I'll defer to Mr. Morgan or any other staff members if it's informative to Manager Valdez's questions.
Mr. Morgan?
Mike, Dr. Bell, can you hear me okay?
I can hear you.
Great.
Thanks.
It's a little quiet, John.
Yes, sir. I'll speak up. So first, I'll just echo Mike's comments and certainly appreciate Dr. Mullen's participation. I've certainly learned a lot personally just from her perspective over the past few weeks. I'd also like to remind the board that, when we created the Medical Executive Board a few months ago, we made a commitment and we were directed by the board to really consider health equity first and foremost as we're making changes in the delivery system and pursuing new clinical initiatives. So, I'm really happy to have Dr. Mullen's participation. I think she certainly brings a lot to the table in these discussions. More generally, and Monica, if it's possible to pull back up the presentation and the system components, I think Manager Valdez, I think you're making a really good point, and it's a really good question. Over the past few years, we've really focused on certain aspects of this system, primarily in primary care. We spent a lot of time developing the urgent care component of that and working with community care. We've built a pretty substantial post-acute care network over the past few years. And, we've not focused on other areas. We've intentionally prioritized some of those spaces. And, one of the purposes of this presentation today was to try to elevate the full system and all of its components, the complexity of the system, and to point out some of the areas that are less developed. And that may still require some significant investments on the part of the board. Some of the areas I would mention in particular, dialysis was mentioned earlier, the intensive outpatient types of services that Dr. Shalsha mentioned. Specialty care has always been a focus of ours, and it's going to continue to be. As you all know, that's one of the hardest things that we work on. And we're going to continue to work on those things, picking a few priority specialties every year to try and make improvements. We do still need to shift a large portion of our services out of the hospital and into the ambulatory surgery centers. And we really wanted to try to put some of this on the board's radar, that some of the investments that we have not made and still need to make to develop a fully functioning, a highly functioning system. So, it can be a lot, it can be overwhelming, and there are aspects of this, even for those of us that, stare at this kind of map every day, it can be very difficult to prioritize and try to make sure that we're working on each of these cogs and getting them to work together. Outpatient dialysis, medical respite, intensive outpatient, telemedicine, those are the types of investments that I think you're going to hear us asking the board to make going forward. And then we can't forget about those aspects in the background, whether it's our benefit plans and how they're structured, our copays and patient financial responsibilities, the technology that we need, the pharmacy network that Dr. Shalsha mentioned. We've got to work on all of these things in tandem. They're certainly dependent on each other. The last comment I'll make, Dr. Bell, and I'll quit talking. Public health and community health is listed on this diagram because it's a critically important piece of the overall picture. Although that is not our piece. We thought it was important to represent it here, that the rest of this can't function if that piece of the system doesn't function. I certainly don't think any of us were wanting to imply that we're trying to take over that responsibility from any of our partner governmental entities. But I just wanted to try to echo that point. Happy to help answer questions.
I just want to thank all of y'all, but I wanted to express from where I was coming in case anybody misunderstood. Let me try and get, I have for years asked that we look at implementing a holistic approach and that we look at all these cogs. I've seen these cogs and worked on these cogs for many years in different worlds. Now I happen to be living in exactly that world that John, you just talked about. Specialty care, respite, hospital care, post-acute facilities, SNFs, rehabilitation. I'm living in those worlds right now as we speak and seeing the gaps that exist between the various systems and in what is not doing the patient a world of good with respect to no counseling anywhere. But with respect to the need for us to work in tandem with our partners and the other governmental entities, I have been asking for this for a long time, starting with the ECIs, starting with the school systems to identify, to work with them as they move through graduation from high school and into our world of possible indigent care, possible community care, possible whatever system. And this is I'm so glad that I am seeing this and I am hearing this, because we had not traveled down this road comprehensively. And the only way that we can work comprehensively is that those partners have to be at the table with us to say, this is your role. Your social determinants of health, housing, Travis County, City of Austin, this is what you need to do. School districts, this is what you need to do. But yet all of us have the same common, we have the same patients, we have the same clients, we have the same population. So as they work through those worlds and in our world at the 200 and less FPL, I see our children, babies being born, then either not accessing resources the way they need to through the school system, and then being dumped out of the school system if they are pushed out as dropouts in middle school or in high school, and then they become people on the street. They become broken families that are in desperate need of resources. And that's why working in tandem with those governmental entities is necessary in order for us to really address closing disparities gaps. That is first and foremost what we actually should be doing. And I'm so happy, Dr. Mullen and Dr. Shalsha, that y'all are presenting this. I'm 1000% behind working on this. I just want to make sure that we don't forget that we need to actually use the lenses of the populations that we serve, the patient, the person that's receiving this care, the minority, historically marginalized populations and patients. And so when as systems are developed, it's normally the people at the top that develop a top-down system. And I want us to look at a bottom-up system where the community and the needs of those communities in all their various races, genders, languages, is basically telling us that this is a good model. How are we going to modify the model to fit their needs, and then go up? And that's all I'm asking for. And if y'all didn't understand that that's where I'm coming from, because the first thing I say is, well, wait, what about our Asian population, our Latino population, blah, blah, blah. And when we look at our targeted population, I want to start there. And I know we can start with them almost from the time that they're born. And that's one of the ways that we can hopefully improve their quality of life as they go through birth to death. And we can work together doing it, just making sure we don't overlap, don't duplicate, and that we, in fact, incorporate and internalize that perspective and that need into our system. Thank you.
Okay. Thank you very much, Manager Valadez. Appreciate it. Manager Jones? You're still muted, Manager Jones.
Thank you. Unfortunately, I don't have the time to pontificate on what we've just gone through. I think that what we need to do, I just have two things. One is we are part of a public health system, a greater public health system. And so we are a subset of that. We are not part of the governmental aspect, but we are part of a public health system. And so for us to feel that we're not, I don't think is an appropriate role for us in our vision. So I want to say that. I won't pontificate on it, but I think everyone understands that. I don't think we need to reinforce that over and over and over again. The second thing, more specifically, is where are we, if you can do it briefly, where are we, have we assessed what has happened over the last 5 years in terms of our planning in anticipation of what we're visioning forth, going forth as a, I'm not new anymore, a relatively new member. What have we done that will foster what we've outlined here we're planning to do? Have you looked at that in the development of this vision here? Can you speak to that?
Who wants to speak to that?
I'd like to start out, and then I'll hand it over to Monica. So yes, we have, but and this is my way of explaining this. But if you look at the work of the prior fiscal years, the next set of fiscal years builds on the other, or builds on the prior fiscal years. And so I think everything that the healthcare district has been doing since inception, I think has been leading up to this point. Now, I'm not sure that I understand your question about the 5-year mark. If you could clarify before I go any further.
We've presented a 5 to 10 year plan over the next 5 to 10 years. And so my question is, in doing that, did we look at what happened the previous 5 years in terms of trying to develop or avoid errors for our next 5 to 10 years in the planning phase?
Yes, and I know there's been various data reports, some connected to the prior demographic reports and some just related to updates to the board that have gone back and looked at historical trends, and you've seen that as well in the community health assessments that you've seen. So the short answer is yes. For purposes of this presentation, they're not compiled and presented here. But also, the other thing that I'll point out about trends and looking back is it seems to me that our the stability of the trend has deteriorated somewhat, meaning what could have been a 5-10 year trend maybe is a 2-year trend. And it seems that things are constantly changing, and I think it's because Travis County is constantly changing. And so I'm not trying to diminish the importance of going back historically and looking at, okay, what has caused this disparity? What is, was it institutional discrimination, or was there some other driving set of factors behind this? That's always going to be important work to know where we're coming from. But the other point is that I think looking forward to say, okay, these trends right here going back 5 and 10 years can be extrapolated forward 5 or 10 years. I don't think we'll have that luxury. I think our trend lines will be a lot shorter. I want to pause there because I know we have strategy and analyst experts on the line and subject matter experts that can complete and better answer the rest of your question. Chair Jones.
So Manager Jones, or sorry, Dr. Bell, I think what a part of what this initial phase of work is to revisit some of the benchmarking that organizations like Germain Solutions have done, and to look, so Germain, part of this work is building off of that work, particularly in some of the areas around specialty care, some of these other areas like John Morgan mentioned, like medical respite, that we're starting to notice are areas that need to be addressed for our population to be served. One of the things that Sarah Cook has worked on with the data and analytics team is looking at, and that this is part of the demographics report that we're still completing, is looking at health disparities across our population. And we can look at those disparities trends over a time period so that we can use that information to help determine what the next steps are, And we also look at utilization trends across the entire system. I think that we are in a different position now where there's an opportunity for you as board members and for us as an organization to really begin focusing on these disparities and the needs of the patients that we're serving in a way that we haven't been able to do in the past. We have, we have support for this work from you as board members, and we have, we're in a different place as an organization to where I think this work is ripe. We can build off the work that was done in the past, and I'm going to pass this off to John, but that we have the ability to approach this work differently from less of maybe just a straight efficiency or financial model, financial ability, financial efficiency model, and really looking at the needs of patients. And John, I'd like for you to be able to speak to
you and Mike have answered the question. I mean, John, feel free to, but we don't have to keep going on. I just wanted to make sure that we inculcated what we've learned from our last 5 years as we go forth. That's what my simple question was.
Thank you, Manager Jones. John, is there something that you feel like you need to add to this conversation? Okay, thank you. Manager Musaiti.
Well, thank you, Chair. Really appreciate it. First of all, I want to thank our presenters, and especially Austin's Jewel, Dr. Jewel Mullen. I really do appreciate everything that you do and you say. Actually, I was in a class and I left it just to hear you, and that really tells about what you bring to this community. And when people say what the value of the Del Med brought, I think it's you and people like you that are really trying to address the inequities and the systems that we've created. Thank you, thank you, thank you. I'm hearing right now, health disparities, health equity, health outcome. Isn't that public health? I just wonder if that is yes or no. That is public health. And we can, and I agree with Manager Jones, public health is a critical component of the work we do, and we will not be able to achieve the health outcomes that we all desire without public health. So what I'm really proposing, highly recommending from this committee to relook, and especially with COVID-19 that we all experience, and we're continuing on to experience the importance of collaborating with public health and seeing where we can build bridges. How can we divert some of our monies with public health? How can public health be part of our meetings right now here to help us navigate the system if we really want to build a system approach that can benefit all? And I don't see us moving forward without that in our equation. And I'll definitely support in moving forward how we can build collaborations and to rethink our system that includes a vital part and component of health, which is really addressing the health barriers outside of the clinical walls. So for our low-income minority communities can benefit and we can alleviate all their hardships and improve their health outcomes. So that's really what I all have to say. And again, thank you so much to everyone and to our Dr. Jewel. Thank you.
Thank you, Manager Musaiti. Chair Greenberg.
Thank you. I want to thank all of the participants today. I want to thank our staff, Dr. Mullen, all of our board members and the public. These have been excellent discussions and presentations. And although people may come from different places, I believe that we all share values in wanting to combat racial injustice, disparities in health equity and health outcomes. And I look forward to seeing us move forward and make great strides. And I want to thank everyone.
Thank you, Chair Greenberg. Do we have any other comments? Manager Valadez.
Hi, Dr. Bell. I think, I don't know who to direct this to. I'm assuming maybe to you, Mike. With respect to the work that we're doing in collaboration with the other entities, especially in light of the passage or the recommendation of that contract that's going to be addressed by City Council and Travis County Commissioners this week. I want to make sure that I'm not mistaken in thinking that we need to be reimbursed for the work that we do. In light of the fact that we didn't get the lion's share of our CARES money or COVID money, and we have such a significant population that has been negatively impacted by that. I want to make sure that we're advocating for reimbursement of that money so that we can continue to work in our communities and do the job as a partner for everybody else, as opposed to just our tax dollars going to support everybody and not getting anything back for our contributions.
Okay, thank you. Manager Musaiti.
I think, Mike, can you answer?
Was that a question?
That was in the form of a question. Is anybody asking for that reimbursement?
Well, first of all, that's not posted for that particular contract is not posted for the agenda, but I know that it was discussed at the board meeting, and I recall discussion on reimbursement from the prior meeting. But I think to bring this back and have a discussion, it'll need to be posted properly for either a committee or a board meeting.
Thank you.
Thank you.
Thank you. I just have a small comment. The health of our community is our health as well, and we are living in unprecedented times, and we have to step up and do what's right for us all. So regardless of whatever we come, I hope we get compensated, but the general population's health will definitely impact us as everyone. So nothing goes to waste. I just wanted to elaborate that point.
Thank you. Thank you very much. Okay. With that discussion, I would like to, before I bring up agenda item number 3, Manager Valadez had a request of personal privilege, and I forgot to acknowledge it.
Thank you.
Before I started the meeting. So I would like to recognize her and allow her to outline her personal privilege.
Thank you very much, Dr. Bell, for recognizing me. I had asked that we take a moment of silence to recognize the death of George Floyd, and I wanted to thank him for the role that he has played to draw attention to the huge gap to the inequities that exist in our systems and the racism that needs to be eliminated as we move forward in all communities and seek to achieve a fair and equal world for every individual alive today. Thank you very much.
Thank you. We'll have a minute of silence in honor of her personal privilege.
No, todavía tenemos más.
Okay, thank you, members. Appreciate it. Thank you, Manager Valadez. Agenda item number 2, agenda item number 3, receive a presentation on Central Health Board reporting dashboards on patient-reported outcomes and patient experience. I have Sarah Cook, Monica Crowley, and John Morgan will be presenting.
Sarah, are you there? Will you share your screen?
Sure. And actually, before we do that, I just want to sort of run through what we're about to present, and then I'm actually going to ask Sally Gustafson, our quality measures analyst, to share her screen and walk through the details of the presentation. So thank you, Chairman Bell. I think that what you're about to have presented to you, these two items, is really important, particularly in light of the conversation that we've had as recently as about 5 minutes ago. So as you've heard earlier from Manager Valadez, and then from Dr. Mullen and Dr. Schulsche, the voice of the consumer is really important. As Dr. Mullen described, it's important for us to know how we're doing so that we can improve. And we know that there are lots of places to look for these data. We also heard from Dr. Schulsche that we need to know how patients feel about their care and their own health. And so I'm really glad to let you all know that we've started this work. And today we can share some results with you. I'll provide some of the background, but as I said, we have Sally Gustafson, our quality measures analyst, ready to answer specific questions that you may have about about our methodology and results. And this was all sent out to you in the board packet earlier. Within the past 6 months, Healthcare Delivery Operations has completed 2 MAP member surveys. The first was our second annual Patient Experience and Quality of Life survey, and that was conducted with a representative sample of MAP patients. And the second was over 200 patients who had a telehealth visit with community care due to our COVID-19 restrictions. The Patient Experience Quality of Life survey shows generally positive experiences with accessing healthcare and a good self-assessment of health by our patients, but there are a few striking differences among race and ethnic groups that we can look at. And the telehealth survey shows almost unanimous support for the COVID telehealth effort and widespread support of continuing the practice. So our first agenda item, the first survey, in 2019, Central Health performed our second wave of patient experience and quality of life surveys, which is a representative sample of MAP patients. And we asked them questions from 2 nationally used survey instruments. Enrollees were asked to rate their mental and physical health, pain, fatigue, and anxiety using 10 questions from the PROMIS survey. These answers are then summarized into 2 global measures, physical health and mental health. Participants also rated their experience of access to care using a series of 8 questions from the CAPS Health Plan survey. And I want you to note as we look at these results that patients are describing their experiencing accessing care across the entire system. We don't limit the question to primary care or to just MAP contracted providers. We compare our results to national benchmarks, and then we can examine what differences exist by racial and ethnic groups. Complete survey results are included in your electronic packet, but there are a couple interesting findings to highlight right now. Between the first year we did the survey, calendar year 2018 and calendar year 19, the percentage of enrollees saying that they always got care quickly jumped from 56% to 65%. Though there are really significant differences that persist by race. And while all groups' self-evaluation of their physical and mental health fell into the good category, none of those groups evaluated themselves as better, if you will, than the national average. The second survey, as we know, on March 19th, community care began shifting patients to telephonic visits in order to maximize their minimize in-person contact, maximize patient contact in response to our social distancing measures. So we quickly composed a 10-item survey with discrete and open-ended responses that were drawn from other telemedicine surveys. So again, going for that other national approach. And we designed the survey so that we could use it again and again as telehealth experience increases. We administered the survey over the course of about 2.5 weeks. And notable points, though, again, all of the results are included in your packet, include that about 82% of respondents asserted that the telehealth appointment was as good or better than an in-person visit. And 66% agreed completely or somewhat with the statement that I would choose a telehealth visit over an in-person visit in the future. we also had the good experience of getting some open-ended responses from patients. I had the delight of performing some calls, and patients were really, really grateful for community care making this rapid pivot to keep both the patients themselves and the community safe. People graded the service as an A+. People said they hit it out of the ballpark, and people were just really thrilled at the convenience and the care that community care and its care teams provided to them. So with those prefatory statements, we can open up, Dr. Bell, to questions as you like, proceed through some of the more granular results, or whatever the committee decides.
Okay, thank you, Sarah. I would sort of ask for the input from the committee. We have some information in our packet that goes into a lot more detail on both the quality of life survey and the telehealth survey. Would you want that presented in detail to you at this time? Or do you want to read it on your own and develop your own questions? How would you like to proceed? Any input from the members at all? Manager Musaitis.
Dr. Bell, I'm perfectly fine with the slides provided, and if we had any direct questions, we can send it through to Sarah or Sat.
And I concur with that.
Okay, thank you, Manager Greenberg. Manager Valadez, you're muted. Still muted.
Okay, there. Thank you, Sherry. Hand signs. No, I'm okay with this. I just want to make sure that Sarah, that whenever we do these or surveys, I know it's difficult to do because you can't always count on who's going to respond and who's not. You don't have any control over that. But if there's any way that we can look at the demographic makeup of the targeted of our population and get surveys based on our demographic, I sure would like for us to go to that. If it means through, maybe it means by getting more, making more calls or trying to make more connections in order to try and equalize that. If you can, you can, but at least I'd like for us to try. Thank you. But thank you for the information. I appreciate it.
And
thank you, Manager Valadez. Sarah, would you
yeah,
respond?
Manager Bell, if I may respond. Manager Valadez, you're absolutely right. And I'm pleased to let you know that the patient experience and quality of life survey we conduct with a representative sample. So the proportion of patients that we sample represent racial and ethnic demographic makeup of our MAP population.
And language.
Yes.
Thank you.
Okay, any other comments, questions? Okay. Agenda item 4, which I think we may have already talked about, and Sarah, you'll have to correct me. Receive a report on the results of the telemedicine survey during the COVID-19.
Yes, Chairperson Bell, I did combine those two items as I read the explanation.
Okay, all right, thank you. All right, so managers, we have already discussed agenda item number 4, and it was an informational item. There was no action to be taken. Agenda item 5 is to receive a report from the Eastern Crescent Subcommittee on items discussed and take appropriate action on items recommended by the subcommittee, including A, the relocation of the Resource Center for Colony Park from Volma Overton Elementary School to Barbara Jordan Elementary School, and B, processes for staffing the Resource Center to be located from Volma Overton Elementary School to Barbara Jordan Elementary School. And Chairperson Jones, I'd like to recognize you for this item, please.
Well, Chairperson, the subcommittee agreed to both of those motions, and therefore I'm just requesting that the Strategic Planning Committee acknowledge that. I don't think we called for a vote on that by the Strategic Planning Committee, but if so, I would encourage that we go forth with approving those recommendations from the Strategic Planning Committee as you so identified.
There is a motion in the packet for that to move it to the to the board, to the full board for consideration. Would Manager Musaitis, are you raising your hand for that motion?
I have a quick question.
Okay, hold on. I'd like to get the motion on the table before I go into any discussion.
Chair Bell, if I may, the motions were written not to direct the actions to the full board. And that is because both of these items are things that are within the current delegation to the CEO from prior actions by the board. So we did not feel the need, and being that subcommittees are not generally tasked with acting on their own, the motion is written such that the committee itself directs the CEO to take actions based on prior board delegation.
Okay. All right. So David, let me ask you a question then, clarify. Do we need this motion or don't we? Because I think Manager Jones had sort of stated that we don't need that motion, so please.
Actually, the way Manager Jones stated it was kind of a motion, was that the committee would support and
the board
essentially ratify the actions that were taken in the subcommittee, which is somewhat necessary because, again, subcommittees don't act on their own. Subcommittees make a recommendation to their committee. So I believe that a motion would be helpful, yes.
I got it. So could you restate the motion?
Okay, I don't have the motion in front of me as written. My recommendation, though, my motion was that we adopt the recommendations of the subcommittee on the Eastern Travis County governing the relocation of the facility at Barbara Jordan and the hiring of staff, or the qualification for looking at staff for the that location.
Okay. Do I have a second?
Second.
Okay. I have a motion by Manager Jones, a second by Manager Valadez. Any discussion? Now, Manager Musaitis.
Thank you, Chair. I just have a quick comment. Can you please, in a sentence or two, wrap what happened in that committee for those who were not present?
Manager Jones, would you like to do that for us, please?
Yes, well, I'll ask staff to join in with me on my own, yes. Basically, the two items that we talked about was that there's a need to be able to relocate and set up our modular at the location at Barbara Jordan Elementary. Staff is in the process of working out the logistics and the financing of that with AISD. The goal is to have it in place and hopefully operated by August or by return of school. The second item related to the hiring of a staff person who would work at this facility that would serve as a liaison and community person, which would be a program manager that would facilitate community outreach, engagement, and activities at that facility for the entire community. And so that was basically the gist of what those positions and that facility would do.
Thank you, Manager Jones. Any further questions, Manager Musaitis?
No, thank you. That was it. I just wanted a summary, a quick summary of what happened. Thank you.
Thank you. I have a motion on the floor and a second. Any further discussion? All in favor?
Aye.
Aye.
Any opposed? Any abstaining? Motion carries. Okay, agenda item number 6. Confirm the next Strategic Planning Committee meeting date, time, and location. Managers, our next regularly scheduled Central Health Strategic Planning Committee meeting is tentatively scheduled for Wednesday, July the 8th, 2020 at 1 p.m. at the Central Health Administrative Offices, 1111 East Cesar Chavez Street, Austin, Texas, 78702. and or remotely by video conference, depending on the status of the governor's disaster declaration and stay-at-home orders. At this time, I'm ready to accept a motion for adjournment.
I move.
I have a motion from Manager Valadez. I have a second from Manager Musaiti. All in favor?
Aye.
Aye.
Any opposed? Any abstaining? Thank you, managers. Appreciate it.
Thank you.
Thank you,
Thank you.
everyone.
Bye.
Bye.